All right. This video is intended to help you get just a general understanding of what vascular function is and how we assess it with Doppler ultrasound. It won't give you the details on how to do ultrasound. That'll come in a different video, but this is just a big picture video. All right, so first we'll start off with what is vascular function and why is it important? And later on, we'll talk about how it's assessed. We'll look at just general concepts with Doppler ultrasound and look at 2 or 3 major ways or common ways that we do in the lab to assess vascular function: flow-mediated dilation, passive leg movement, and exercise blood flow during knee extension exercise. All right, so why does blood flow matter? Blood flow is extremely important for exercise and for life. Simply put, without blood flow, you die, okay? And with poor blood flow, you can't exercise very much. You've seen when people get a heart attack, that stops blood flow, right? The heart stops, you have less blood flowing in the heart can't work anymore and you die. People who have peripheral arterial disease, they get clots, big atheromas, or lesions in their arteries, and it limits how much blood can get down to the muscle. And by having low blood flow, their exercise capacity goes really far down. So one of the equations that you need to understand for exercise physiology is the Fick principle. And this is the Fick principle. And what it tells us is that the VO2, or the rate of oxygen consumption, how much oxygen you're consuming, is influenced by blood flow and then the arterial venous oxygen difference. So if we want to look at how much oxygen your whole body can consume, we look at blood flow coming out of the heart. So we would look at cardiac output, which would be the Q that we're looking at here. So if you want to look at how much oxygen you can consume, you look at how much blood comes in and out of the heart, and then look at the difference between oxygen in the artery side. This would be content of oxygen in the arteries. So the big C is content, little a, you can't tell that's an A. The little a means arterial. So the content of oxygen in the artery versus the content of oxygen in a vein, the CVO2. The difference between those two things is the AVO2 difference. Okay, so really we just look at how much oxygen is going out of the heart and how much comes back, and that tells us how much is being consumed. What I want you to understand from this is that blood flow is extremely important here. If we're looking at the VO2 of the whole body, we look at cardiac output. If we just want to look at the VO2 or oxygen consumption in the leg or in some kind of muscle like that, like the quads, we would look at blood flow through the femoral artery, and we'll see that in a second. But without blood flow, you get no VO2, and without oxygen consumption, you don't get aerobic ATP resynthesis. Without ATP, you can't do exercise and you die, okay? So blood flow is extremely important here. One of the things, I'll just illustrate that with a study I did a couple of years ago. And in this study, we measured multiple factors to get the VO2 of the leg during exercise. We had the individuals do single leg cycling or knee extension exercise. And we measured blood flow to the leg and measured how much oxygen was going into the leg through the femoral artery and how much came back through the femoral vein. That would tell us the AVO2 difference, and with that, with the cardiac or with the blood flow at the femoral artery and the AVO2 difference, we were able to calculate the VO2. Now we did this in a group of trained and untrained individuals. So our trained guys were endurance athletes like cross-country skiers, cyclists, marathon runners, and our untrained were just your average college student. Now, what you can see in black here, these are the trained and untrained individuals. They, as we increase the work rate, or how fast they're pedaling, how fast they're going, how much work they're doing every minute, power, the VO2 goes up linearly. Very, very common. But they got to a point where they couldn't exercise anymore and they hit a max there, right? Then the trained guys, we had them do the same exercise. They started off at low intensity, and as they went up, the VO2 for a given workload was roughly the same. That's very predictable. It costs you a pretty predictable amount of ATP to do a given exercise. And so while the trained and untrained are doing the same exercise, they should consume the same amount of ATP and the same amount of oxygen. So the VO2 is about the same, but the difference is the trained people could keep on going up to higher rates of oxygen consumption. And that's paralleled in blood flow. So femoral artery blood flow, your untrained people would stop right about here at about 50 watts. They get about 4,500 milliliters of blood going through the femoral artery every minute. Then you get your trained people, same blood flow, more or less, pretty close at a given exercise, submaximal, but they can keep increasing to higher work rates and get higher blood flow. That high blood flow allows them to have a high VO2. So high blood flow allows them to have a high VO2, which means high rates of ATP resynthesis and a lot of work that they can do. Blood flow is extremely important for exercise. So what influences blood flow? Blood flow, we can calculate it by Poiseuille's law. This equation just tells us the factors that influence flow through a tube, whether it's a straw, a hose, or an artery. It's the change in pressure from one side to the other. So the pressure going in the artery and pressure pushing back on it at the vein, that difference in pressure, perfusion pressure, or pushing pressure is another way to think of it. And then vasodilation, or the radius, okay? So we have change in pressure, pi, constant, radius to the fourth power, an 8 is another constant, N and L, these are viscosity and length. These two factors, they're not going to really change all that much. So in a human, most of the time during acute exercise, our change in blood flow is either going to come from a change in pressure, so systolic blood pressure or mean arterial pressure, probably more accurate, versus mean venous pressure. That's kind of fun. It's MVP, mean venous pressure. This will go up maybe 40%, 50% during exercise. So it goes up, but not a lot. So the majority of our increase in blood flow is coming by dilating the artery, making the artery bigger. And it's to the fourth power. So what that means is a small change in radius has a big impact on how much blood can flow through down to the muscle. In fact, if let's say we double the change in pressure and double the change in radius. So if we double the change in pressure, blood flow goes up, it doubles, okay? It's a one-to-one relationship. Unfortunately, pressure doesn't double during exercise. That usually isn't that great for you, this perfusion pressure. Now, so doubling pressure, doubled flow. But if we double the radius, since it's to the fourth power, a doubling in the radius will give you a 16-fold increase in blood flow. Huge changes in blood flow by the change in the radius. So a lot of the studies that we do in our lab look at how well these arteries can change their radius. Because a big change in radius equals a big change in flow, and flow allows you to exercise more. So what factors influence how much the artery can dilate? Let me think here. First off, when we're looking at this change in radius, depends on what we're looking at. If we want to look at just one artery, it would be the radius of that one artery. But when you get down to the level of your muscle, you have thousands, if not hundreds of thousands, of these little arterioles. So that would be, instead of it being one artery, let's say you got artery 1, artery 2 over here, artery 3 over here, artery 4, right? You got all these arteries. It's going to be the total radius. Sorry about that. My pen's doing something funny. So it's the total radius So all those little tiny arterioles in your muscle, they'll all dilate a little bit. And with each of them dilating a little bit, that adds up, okay? So if we just want to look at one artery, like the femoral artery, we can just measure the change in the radius of the femoral or the brachial artery. But when you exercise, bear in mind that the radius is much more of your change in radius is coming down in these little arterioles that we just can't see with any of the equipment that we have right now. All right, so what influences how much the radius changes, or the size of the radius? By default, one of the first things, your resting blood flow is going to be influenced by how many of these little arteries you have. If you only have like 100 little arterioles, that's not going to be a lot of flow. If you have a giant leg with a lot of arterioles in there, that's going to be a lot of flow, okay? Because every little artery adds onto that radius. So the more arteries you have, the more arterioles you have, the greater the blood flow. And you'll see this, people with a small leg, with like a really tiny quad, they don't have a lot of muscle in there, they don't have a lot of arterioles, not a lot of capillaries, so not a lot of flow. But if you get like one of these giant football players in there with a big leg, they'll have a lot of arteries in there, arterioles, a lot of capillaries, and that means they'll have big resting blood flow. On average, you could have like a tiny little person, let's say like a BYU gymnast, one of these little gymnastic girls, they have small, even though they're ripped, they have smaller legs, they're just small people, right? So their resting blood flow in their leg would be about 200 to 300 milliliters per minute. If we get one of these big football players, their legs probably twice, if not 3 times the size, and their blood flow will be twice or 3 times the size, up to about 600 milliliters per minute at rest. Okay, so just how big the leg is and how many arterioles in there influence that radius to begin with. Now, when you want to, during exercise, we dilate the artery, make those radii, the radius of the arteries bigger. And what influences that, for the most part, is this endothelium. So here we have an artery. You have the outside of the artery, adventitia. We have smooth muscle in here. This is what's going to contract or dilate. As the smooth muscle contracts, it brings the artery in closer and narrows the lumen, or the inside of the artery. As it dilates, as the smooth muscle relaxes, it dilates and gets bigger. Now, you have some factors that can cause the smooth muscle to dilate or constrict without any influence of the endothelium. But for the most part, this tiny layer of cells in here, the endothelium, is what's going to tell the smooth muscle to constrict or dilate, to contract or relax. This tiny layer of cells is the boss of the artery. It tells it how much to dilate by releasing different chemicals. It tells it to constrict. And so it's extremely important that way. One of the most important factors that the endothelium releases is a gas called nitric oxide. Now, nitric oxide is a very small gas released by the endothelium. It has an unpaired electron here, so it's highly reactive, and that's going to be key in a second. When the endothelium releases nitric oxide, in response to lots of different things, hormones like insulin will cause nitric oxide release. Friction from blood moving through there causes nitric oxide release from the endothelium. Heat causes nitric oxide release. When that nitric oxide is released, it diffuses from the endothelium to the smooth muscle and causes the smooth muscle to relax or stop contracting as much. And that means the artery gets bigger. That radius is getting bigger. That means more blood flow, right? So in your head, nitric oxide should mean greater blood flow. Not only does nitric oxide cause the artery to dilate, but it also inhibits a lot of nasty stuff that happens with aging and disease. It inhibits plaque formation. So atherosclerosis is the accumulation of plaques, right? The more nitric oxide you have floating around, the less that plaque is going to form. So if we use this to our advantage, we can say the more an artery dilates, the more nitric oxide it has. And the more nitric oxide it has, the less likely you are to have cardiovascular disease and plaques and atherosclerosis and thrombosis, right? So we really, in all these tests I'm going to show you later, we use how much the artery dilates as a window into the vascular health. It doesn't just tell us about blood flow, which is extremely important, but it also tells us what kind of environment that artery is exposed to. If it dilates really well, if you get high increases in blood flow, that probably means you have nitric oxide and things are healthy. If you don't get a big increase in blood flow, that means that you probably have an environment that favors atherosclerosis and different cardiovascular diseases. Right? So how would you have low nitric oxide? Well, a lot of different factors happen. You have this enzyme, nitric oxide synthase, that makes nitric oxide. And if you don't have a lot of that, you're not going to get a lot of nitric oxide made, okay? So that can impact it. But usually with things like aging and disease, we see the enzyme there, or the machine is present to make the nitric oxide. But what happens is the nitric oxide gets intercepted in its transit. Remember, normally the nitric oxide diffuses from the endothelium to the smooth muscle and causes smooth muscle to dilate. What happens in disease is that it gets intercepted. So that nitric oxide, you can hardly see it here, but right there, that's an unpaired electron. And when you have an unpaired electron, that means it's going to react and grab anything that has an extra electron really fast. And in aging, you get a lot of these things called free radicals or reactive oxygen species, ROS, which are just unpaired electrons, chemicals, molecules that have unpaired electrons. Now, if you have a lot of these unpaired electrons around, the nitric oxide is going to get intercepted or bind those instead of the smooth muscle. And without nitric oxide around, the artery can't dilate and it might even constrict. And without nitric oxide around, you're going to have the first steps of atherosclerosis because you don't have the nitric oxide to keep the atherosclerosis from happening. And that increases your risk of different cardiovascular diseases. So really, what this endothelial or vascular endothelial function, if you can't dilate your arteries, that's a sign of a dysfunctional endothelium. And endothelial dysfunction is the first step in most cardiovascular diseases. In fact, you can take a person when they're 30, 40 years old, and if they don't dilate those arteries very well, that's evidence of the very first steps towards cardiovascular disease. This endothelial dysfunction, inability to dilate the arteries, which would accompany low nitric oxide availability and high risk of the first steps of atherosclerosis. This endothelial dysfunction is the first step in cardiovascular disease, and it occurs and starts decades, 10, 20 years before you get any overt symptom of cardiovascular disease. 10 to 20 years before you see any plaques accumulating. Before that happened, you had bad nitric oxide availability, right? So it's the first step. But fortunately for us, with it being the first step, not being able to dilate, having low nitric oxide availability, it's the first step, but it's also very changeable. So we can intervene early on. So if we find one of your friends has bad nitric oxide availability, they can't dilate their arteries right now, even though they're just 25 years old. If we get them in here and exercise train them, or if we give them certain medications, we can make those arteries dilate well. We can make those arteries have good amounts of nitric oxide and other healthy chemicals, and that will keep the arteries clean. Think of nitric oxide as your toothpaste, right? If you're constantly brushing your teeth, you're going to keep those teeth clean. If you don't have nitric oxide around, you're not brushing your teeth, and those arteries are going to gradually, little by little, accumulate plaque. And you've probably known someone that didn't brush their teeth. The first day they don't brush your teeth, you probably don't notice. Second day, still don't notice, except for maybe they have bad breath. But after a couple of months, you can see a bunch of junk on their teeth, right? Same idea with your arteries. If you don't have nitric oxide around, which is effectively brushing your arteries, you don't have that around, after years of that happening, you're going to start seeing plaque accumulate in the arteries, which is atherosclerosis, which gives you risk of heart attack. It also increases your risk of high blood pressure and all these other things, right? So endothelial function is super important for having healthy arteries. Here's some really cool data. So in a study in 2009, Yeboah et al., they measured vascular endothelial function. on a bunch of people, and then they followed them for several years. What is this? 1,500 days. What is that? Like 5 years, somewhere around 5 years. So they measure their endothelial function or vascular function day one, and they follow them for 5 years to see what happens to them. Individuals that had good endothelial function at baseline on day one had a much lower risk of having heart attack, stroke, and all these other things than individuals that had poor endothelial function at baseline. Okay, so this is a survival chart. And what that means is if you're surviving from something, and in this case, what we're trying to survive from is having some kind of cardiovascular event or disease, like a heart attack, stroke, something like that. So if over the course of our follow-up, our 5 years, if no one ever had a heart attack or stroke, we'd see a straight line, okay? That would be the best possible outcome for this. But that's not exactly what we see. We see that people that have good endothelial function at baseline, a couple of them are getting cardiovascular disease, but much less than the people that have poor endothelial function at baseline. Not as many survivors, okay? So vascular function is extremely important for cardiovascular health, but it's also extremely important for exercise capacity. This is a test I'll show you in a minute. This is called passive leg movement, or PLM. We're measuring how much blood flow they can get in response to just moving someone's leg back and forth. It tells us a lot about how much nitric oxide is around and how many arteries are around. What we did a couple of years ago was we measured vascular function with this PLM test and then compared it to how much blood flow they could get during maximum exercise. And your vascular function, that's represented here by PLM flow peak. So how healthy your arteries are is highly related to how much blood flow you can get, right? So if you have a lot of arteries around that can dilate really well, you're messing with that R to the 4th power, which means you can get really high blood flow. So good vascular function is predictive of having really high blood flow. And if you have high blood flow, that means you're delivering lots of oxygen to the muscle, and you can have a high VO2 and high exercise capacity, right? So vascular function has an impact on your exercise capacity as well. So how do we assess this? How do you assess vascular function? Well, most of the time in the lab, we use something called Doppler ultrasound. So let's talk about that. Doppler ultrasound, fancy little machine, looks something like this. Lots of different variations of it you'll see around BYU. The screen on here looks just like this. I'll talk about that in a second. And then you have these transducers. The transducers or probes get placed on the skin over the artery of interest. Most of the time in the lab, we'll do the femoral artery, but we can do it over any artery in the body, whether it's the feet, the legs, the head, the neck, whatever, okay? These transducers go over the artery and they send out sound waves. And depending on how those sound waves get reflected back, well, it uses how the sound waves are reflected back to generate an image. So in this image, we're looking deep. So this would be like the skin up here, and we're just going deeper and deeper into the muscle. And then we have skin. This would be maybe some muscle there, probably more like fat. Yeah, it's definitely fat. And then we finally get down to the artery here. This black hypoechoic or low reflective. This black spot is where the artery is. And then below that, now we have some muscle, right? So the ultrasound sends out these sound waves and they get reflected back by different tissues and it tells us what's there. When we do Doppler ultrasound, we're not just getting the image. So one set of sound waves goes down and tells us what everything looks like. Another set of sound waves go and they're reflected off the red blood cells. So you can't see it in this picture, but there are a lot of little red blood cells around here. And the ultrasound is sending these sound waves down and they get reflected off of the red blood cells and they come back. Now, you might remember the Doppler effect. Let's say I'm a terrible drawer, but let's say this is a car. You can judge how fast a car is going if you're standing right here this is a terrible idea, don't do it in real life. If you stand right there and you throw a tennis ball, that tennis ball is going to bounce off of the car and come back to you roughly at the speed at which the car is moving. Okay, so that's the speed of the tennis ball is going to come back and tell you how quickly the car is moving. I don't recommend standing in front of a car to do that. So you could do it on the back side of it. You throw that tennis ball and it'll bounce off the back of the car and come back to you slower than when you threw it because it's bouncing off something moving away. If you throw it at something that's moving towards you, like a car or a baseball bat or a tennis racket, that ball's going to come back faster, right? And how much faster it comes back tells you how quickly the tennis racket or the car or whatever was moving, okay? So that's called a Doppler shift, this change in speed of the sound waves due to the moving object. The other classic example of Doppler shift, you've heard like sirens when a car's come or a police car is coming by you. As it gets closer, the sound gets louder and higher, and then as it gets further away, the sound gets lower. Okay, that's a Doppler shift. As the car moving towards you increases the frequency at which the sound waves hit you. As the car moves away from you, the frequency at which the sound waves reach you is lower. So the sound's lower. So in Doppler ultrasound, we're sending sound waves to bounce off of these red blood cells. But the thing is, these red blood cells are moving. So they bounce off and then it comes back to the transducer. And how quickly they come back tells us how fast the blood flow is moving. So in this picture, we have the artery, the radius, or the diameter. To get the radius, you would just divide diameter in half, right? And we also are getting the velocity. So this down here is the blood velocity. So we have two sets of sound waves, right? One set of sound waves gives us this picture, and that's called B mode or brightness mode picture. The other set of sound waves comes from pulse wave mode or PW mode or Doppler mode. It's called a lot of different funny things on different ultrasounds. It tells us how quickly the blood is moving. And what's cool is you can see it at rest, you'll be able to see how this blood flow is influenced by heart rate. So here's an EKG tracing down here. And every time you see a spike, that's an R wave, that represents the heart contracting. So you can see every time you get a spike, we're measuring this in the arm actually. So a spike represents the heart contracting, and a couple of milliseconds later, a pulse of blood makes it to the arm. And you can see blood moving really fast, and then it slows down after the heart's relaxing, while the heart's relaxing. Okay, so you can see the pulsatile nature of the blood velocity, fast, slow, fast, slow, fast, slow. That corresponds to the heart rate and heart contraction. Now this is important because we calculate blood flow by measuring blood velocity. So that's going to be this chunk down here on the ultrasound, the pulse wave, by the radius to the second power, pi r squared, right? And we get the radius from the image. So with this, we can measure blood flow. Any artery you want, you can measure how much blood is flowing through there. So most of the time we'll measure the femoral artery and use that as an index of how much blood is going down to the whole leg. The femoral artery feeds most of the leg, quads, hamstrings, calf. Most of that blood is, almost all of it, if not all of it, is coming from the femoral artery. So we'll use that to measure how much blood is going down there. All right, so how do we assess vascular endothelial function? There's a couple of ways to do it. Probably the gold standard is to stick a needle into an artery. So let's just draw a needle in here and infuse a chemical. This is acetylcholine. Acetylcholine is a dilator. It binds to that endothelium. Oh, I haven't shown you that, gosh. On this ultrasound, so we have the black spot is the lumen or the inside of the artery. And then you can see here, this little line, that line is going to be the endothelium, that single layer of cells. That is the endothelium. And then the dark spot right after the line, it'll be bigger in different pictures, but you can see kind of a dark spot right there, right under the bright part of the endothelium. That dark spot is the smooth muscle. Muscle doesn't show up very well on ultrasound, so it's usually dark. And then this bright line deeper, that's going to be the adventitia, or that outer layer of the artery that shows up really well. So we can see the endothelium right there on the outside. How do I draw this? So that's going to be the endothelium. And then this black spot is the smooth muscle. And then the lighter spot, that's the adventitia. Sometimes you'll hear, instead of endothelium, you might hear intima. So endothelium often is referred to intima because it actually, this thing that we're looking at, it's the endothelium and something called a glycocalyx, which is just a couple of like basically sugars coming off of the endothelium, reaching out and trying to grab a bunch of insulin and other hormones, epinephrine, norepinephrine, all these other things floating around, right? So you can hear, the endothelium is often called the intima, but technically the endothelium is part of the intima, but like 90% of it. Then you have the smooth muscle, which is often called the media. And then the adventitia is just called the adventitia. It's just that fibrous wrapping around the artery. All right, so where was I at? That was just to help you figure out what's going on in the image. But the gold standard to figure out how healthy your arteries are is to infuse a vasodilator like acetylcholine. Acetylcholine comes in and it binds to receptors on the endothelium and causes them to release nitric oxide. So any increase in blood flow or dilation, this artery would expand outward to be like that big with the acetylcholine. Any increase in blood flow or dilation, that's going to be because acetylcholine is causing the release of nitric oxide and other endothelial dependent or things released by the endothelium, okay? As you can imagine, it's not a lot of fun to stick needles in people's arteries, especially big ones like the brachial artery or the femoral artery, heaven forbid, the aorta. So we don't like to do that very often, and we're not gonna do it here at BYU. We're just, they don't let us put stuff in needles in people's arteries. You need like an anesthesiologist to do that, okay? But the magnitude of dilation that happens, that's the gold standard. That's really how we know how healthy the arteries are. The other things I'm about to show you have been shown to do about the same response and be extremely related to this invasive test, flow-mediated dilation, FMD, and passive leg movement, PLM. Both of these have been shown to be very predictive of this infusion, give you pretty much the same results without having to stick them with a needle. So let's go in and look at that. So flow-mediated dilation. In this test, we don't do it in the lab as much as we used to. You measure the size of the brachial artery, or often the femoral artery, superficial femoral artery on the leg, or popliteal artery. You measure the size of the artery at rest. So we get this diameter at rest, and then we stick a cuff on. And we inflate the cuff to where there's no blood flow. So you can see here, we don't have much flow going on. That's because the cuff is inflated to like a tourniquet and it's cutting off blood flow. So we don't get a lot of blood flow on. So you measure the diameter before you put the cuff on, inflate the cuff, and then you're gonna measure it afterwards. When you release the cuff, so right here, we're releasing the cuff, and blood rushes down that artery. So we have a huge increase of blood flow. We're going from essentially 0 milliliters per minute right there, to probably like 100 and, no, we're probably like 1,000 brachial, probably 400 milliliters per minute in the brachial artery. So huge change in blood flow, right? So now we have a lot of blood flowing through the brachial artery, femoral artery, wherever we're measuring. And that blood flow causes a lot of stress or friction on the artery. And friction, or shear stress is what it's called. Shear stress stimulates the artery to the endothelium to release nitric oxide. And so when we release that cuff, the shear stress from friction goes up, nitric oxide is released, and the artery gets bigger. So you would see, if this is the size of the artery during rest, after cuff release, it might get that big, right? That's probably an exaggeration. Really, when we do this test, the change in artery diameter is pretty small, and you can't see it with the naked eye. We have to use special software to measure it pixel by pixel. So this one measures the function and health of the conduit arteries, these bigger arteries. And we've done studies where if you measure the function of the conduit artery in the arm, like the brachial artery, this flow-mediated dilation, it's very predictive of the health and function of the conduit arteries in your heart, right? So we can use what goes on in your arm to predict what goes on in your heart without ever sticking needles in you and exposing you to x-rays and all these other things and putting ink dye in, which is necessary to measure coronary heart artery function. So it's a very good surrogate there, flow-mediated dilation. Oh yeah, so here, if this is diameter, let me erase all this. So this is a measure of diameter. So the diameter is going to be pretty constant at rest. If we zoom in on it during diastole and systole, it'll go up. During systole, when the pulse is coming through, you'll see a spike, and then diastole, the diameter will go down, but it'll be a very small change. So it'll just be kind of like this, really, all centering around the same spot usually. Then when you release the cuff and you get dilation, if we zoom in, it's going to look something like this. And then it'll come back down over like a minute or so. So usually within the first minute of cuff release, we find a peak dilation. And all flow-mediated dilation is measuring the percent change from here to here. And on average, a healthy dilation, like in the brachial artery, around 10%. So 10% increase in the size is what you'll see in like a healthy young college student athlete, healthy older adults. If you get sedentary people or sedentary adults, you'll see maybe around a 3-4% dilation. If you get really unhealthy people, like with cardiovascular disease, you actually wouldn't see a dilation at all. You might see nothing, right? Very little change. Sometimes you might even see a constriction. So 10% is kind of like the highest you'll see if it's done right in the brachial artery. Other arteries like the superficial femoral, maybe around 5% is most you'll see. I already showed you this. This one. It's very predictive of how, this is the one used to determine someone's risk of developing cardiovascular disease with that survival curve. We already saw that. We've done studies, lots of people have done studies blocking nitric oxide, that enzyme, nitric oxide synthase. You infuse a drug into the artery to turn off that enzyme so you don't have nitric oxide around. And if you do that, the dilation decreases. So what that tells us is that flow-mediated dilation is dependent on nitric oxide. So it's an indicator of how much nitric oxide is floating around in that conduit artery. And estimates somewhere around 20, sometimes 80%, depending on the study. Most of them are around 20 to 40% mediated by nitric oxide. If you take out nitric oxide, it's blunted by 20 to 40% in a healthy young adult. There's another test that we do quite a bit in the lab. This is called the passive leg movement test, or PLM. And in this test, what we do is we trick the muscle into thinking that it's exercising. And we do that by moving someone's leg back and forth for them. So a member of the research team grabs the leg and just moves it through a 90-degree range of motion back and forth for about a minute. The test subject, is completely relaxed. They don't contract or exercise at all. So it's just the stretching of that muscle and the arteries within it. It causes the release of nitric oxide and dilation. It tricks the body into thinking it's exercising. So if this is resting blood flow, somewhere around 300 milliliters per minute, when we start to move the leg, you get an increase in blood flow that peaks out somewhere around 20 seconds in and into the movement and then decreases as you keep moving. It gets used to it, figures out that you're tricking it, I guess. But that increase in blood flow, this number here, that peak blood flow, or the change from baseline to peak, delta peak, that triangle's a delta symbol, that change from baseline to peak is very indicative of vascular health and nitric oxide availability, or the total increase in blood flow. So this AUC is area under the curve. That total increase in blood flow tells you also how healthy the arteries are. Eventually it goes back to baseline, right? So just this whole shaded area would be the area under the curve, the total increase in blood flow. Now, why is this important? We've done studies in the past where we found in healthy young people, if this is their response to the passive leg movement, when we infuse saline or a placebo, then when we do the same test again on the same person, but we infuse nitric oxide inhibitors, the response is blunted, anywhere from 40 to 80% in a healthy young adult. So this is very dependent on nitric oxide, right? So taking nitric oxide out, you have a low response. So you can kind of assume if you have a person that has a low PLM response, you might suspect that they have low nitric oxide availability. Okay, especially if you see a change in a person. Like I did studies in the past where we had people come in on clean air days and then again on polluted air days. Salt Lake, Provo gets pretty polluted in the winter. And on those polluted air days, we would see their vascular function down like this again, indicative of them really not having a lot of nitric oxide around, probably because there are a lot of those free radicals gobbling up the nitric oxide, intercepting it before it could get to the smooth muscle. All right, so this vascular function test of PLM, we see lots of differences between young active people. So this would be like a young active adult, 20-year-old, sedentary 20-year-old. This is an active 60, 70-year-old, sedentary 60, 70-year-old. And then this is a person with heart failure, okay? So the healthier you are, the bigger the response. Also, the bigger your leg, the bigger the response. And we'll talk about that on another day. So this vascular function test, passive leg movement, one of the reasons it's so important is it gives us a really good idea of how much blood flow their leg can accommodate. And remember, how much blood flow your legs can get is really one of the main determinants of your VO2 max, or how much oxygen you can consume and how much exercise you can do. A couple of years ago in a study I did with one of my graduate students, Brady Hansen, we measured vascular function with PLM exercise. I showed you this already with PLM. So we measured their vascular function and we looked at the peak flow. So we're looking at what this value is, or all the way back here, the peak. If we look at that peak blood flow that they get is highly predictive of the maximum blood flow they can get during exercise. So we measured it during blood flow during passive leg movement, and then we made them do active knee extension exercise and measured the max they could achieve. So what this tells us is vascular function, good resistance artery function. Passive leg movement is a measure of resistance artery function. If you have good resistance artery function, that means that you can accommodate really high blood flows and probably high intensities of exercise. So that's another reason why vascular function tests like PLM are important. All right, so we looked at FMD, PLM, and now we're going to look at measuring blood flow during single leg knee extension exercise. This is another test that we do quite a bit in the lab. We'll put people on this funny chair, and the chair is sitting on top of a bike. So you can see the bike pedal there, and you can't see it in this picture so well, but there's a flywheel or just a normal bike wheel. So we got Jason on here. His leg is strapped to a pole that then goes onto a pedal. So he kicks out and pedals the bike, okay? Now, why would we do this? let me start it so you can kind of see what goes on. Why would we do single leg knee extension? Well, because it's such a small muscle mass, it's an exercise that is not limited by the heart. So you get the maximum blood flow you can get because of dilation of those arteries, okay? So the highest blood flows that have been observed per kilogram of muscle have been during this exercise. So it really tells us the maximum blood flow capacity of the muscle. Also, we can make measurements during it. Try making an ultrasound measurement during cycling or during running. It's extremely difficult, if not impossible. We can measure blood flow at the femoral artery during knee extension with practice. It's not something you'll do your first day. It'll take a couple of months, but you can do it. Also, another important thing with knee extension is we know exactly what muscle is involved. Because we only have the person extend out, and then the flywheel and the pedal pull the leg back for them. So they don't have to actively contract. The hamstrings aren't active. It's just kicking out with the quad, and then the hamstring or the flywheel pulls it back. So it's only the quads that are active, and we can quantify how big the quads are pretty easily. So we know how much muscle is doing the exercise. When you're doing cycling, all the different muscles in your leg are active to varying degrees. You might have your quads active to like 90% of their capacity, the hamstrings, let's say 60%. Then who knows how much your tibialis anterior is active, or your soleus, right? And you also get like the glutes that are active, but you can't measure blood flow for all of these at once. So that's why the knee extension is so nice, because we can measure blood flow during the exercise and we know exactly where the blood is going, okay? So we'll do all these same principles with ultrasound we do during active exercise. And this tells us, again, how healthy the arteries are, how much blood flow they can accommodate, and how much exercise they can do. If you can increase blood flow to a person's leg, there's a good chance you can increase their exercise capacity. Not always, but there's a pretty good chance you can. All right. Yeah, so this comes back to a study I showed you a little while ago. I had endurance trained and untrained people do this knee extension exercise. Untrained people could only hit about 50 watts, and that 50 watts is consistently associated with about 4 liters per minute of blood flow. The endurance trained people, at 50 watts, they got that same 4 liters per minute of blood flow, but they could keep going higher and higher. They achieved much greater rates of blood flow. Instead of about 4 liters per minute, they got about 5-6 liters per minute during this knee extension exercise, or 6,000 milliliters per minute. So the higher blood flow allows them to do greater rates of exercise. That blood flow, of course, if you have more blood flow, you need more mitochondria to do the exercise, and multiple other pieces need to be upgraded when going from untrained to trained, but blood flow is a huge part of that. And so that increased blood flow allows for an increased VO2 max. All right, so that's all I'll cover in this video. I've probably overwhelmed you by now. We've talked about why vascular function is important, what it is, why it's important. Sometimes in papers, you'll see it called endothelial function, other times just vascular function. Vascular function is the umbrella term. It's much more general because there are a lot of other things besides the endothelium involved in dilating arteries and the health of the arteries. Endothelial function is very specific to just that endothelium. Most of the time now we just refer to vascular function because there's in FMD, PLM, all these other tests. It's not just the endothelium that's involved. The endothelium is extremely important and probably the majority of the response, but there's other factors involved. So we refer to it more generally as vascular function now. So we've talked about vascular function. We've talked about the different assessments of vascular function using ultrasound. In future videos, you'll get more in depth about how to do ultrasound and how to do these different tests, but we'll call it for now.